My name is Dr. Aaron Kaufman from CDC's Viral Special Pathogens branch. This presentation is for healthcare providers and will cover important information about Lassa fever. At the end, you will be able to describe the risk factors, endemic areas, and incubation period for Lassa fever, and identify the clinical presentation of a Lassa fever patient. I will start with an overview of Lassa fever virus, then move on to the epidemiology, and then review the clinical presentation of Lassa fever. Lassa virus is an Old World arenavirus. The virus is named after the town in Nigeria where the first cases occurred in 1969. Lassa virus is an enveloped virus, meaning that the virus is coated with a lipid membrane. This membrane makes it very susceptible to disinfection, and it is easily killed by household bleach, detergents, soap, and other disinfectants. Genomic sequencing of Lassa virus strains has revealed high sequence diversity and at least 6 major genetic lineages which correlate with geographic location. The high degree of sequence divergence of Lassa virus genomes poses a significant challenge to the development of molecular diagnostic technologies. For many years, Mastomys natalensis, also known as the multimammate rat, was assumed to be the sole rodent reservoir for Lassa fever virus. This rat has been found in West, Central, and East Africa. Additional rodent hosts have been recently identified, but their contribution to human illness is unknown. Lassa virus infection does not cause any apparent illness in the rodent. Infected rodents can shed the virus in saliva, urine, and feces for the length of their lives. Lassa virus is maintained within the rodent reservoir and is transmitted from rodent to rodent primarily by fighting, through bites and scratches from one infected animal to another. People can contract the virus from rodents through direct contact with infected rodent droppings, urine, saliva, tissues, or blood, and by being bitten by infected rodents. As we know, infected rodents shed Lassa virus in their urine, saliva, and feces. When fresh rodent urine, droppings, or nesting material is stirred up, tiny droplets containing the virus can get into the air. People can contract the virus by inhaling aerosolized urine or droppings. People can also contract the virus by eating food contaminated by rodent urine or droppings. Finally, in parts of the world where rodents are part of the diet, people may get infected when preparing rodents for cooking. In one study in Guinea, Mastomys comprised from 95 to 98% of rodents captured inside homes. The same study found that the mean trapping success of Mastomys was always higher inside houses than in proximal cultivation. During dry season, mean trapping success increased 2-fold inside homes and decreased up to 10-fold outside homes. Another study in Sierra Leone examined housing characteristics and rodent density, and found that ceilings, roofs, food stocks, and cooking appliances were frequently infested with rodents. Finally, studies in Sierra Leone and Nigeria have found an association between house hygiene, defined as waste disposal and food storage, and a history of Lassa fever in the household. Lassa fever is endemic in many countries in West Africa, including Sierra Leone, Liberia, Guinea, and Nigeria. In addition, isolated cases have been reported in Côte d'Ivoire, Burkina Faso, Mali, Togo, and Benin. Since 1969, 33 Lassa fever cases have been exported to countries outside of West Africa. 8 cases have been imported to the United States. Of these, 2 patients were suspected of having Lassa fever in their originating country and were medically evacuated to the United States for care. 6 patients traveled to the U.S. by commercial airliner and were diagnosed with Lassa fever upon arrival. In endemic countries, the peak incidence of Lassa fever cases occurs during the African dry season, which typically runs from January to May. It has been estimated that there are 100 to 300,000 cases in West Africa each year, with 5,000 deaths per year. One study found that in parts of Sierra Leone, Lassa fever was responsible for 10 to 16% of all adult hospital admissions. 80% of those infected with the Lassa virus experience mild or no symptoms. 20% develop severe multisystem organ disease. The case fatality rate among hospitalized patients is 15 to 20%. Death is usually because of multi-organ failure. This graph depicts the incidence of Lassa fever cases and non-Lassa febrile illness by month and average monthly rainfall in Sierra Leone over a 1-year period. As you can see, there is a peak in Lassa fever cases during the dry season. However, over the course of the dry season, Lassa fever incidence tends to be stable. Non-Lassa febrile illness incidence tends to vary more during both dry and wet seasons. Lassa virus can spread person to person through broken skin or mucous membranes, by direct contact with the body fluids of a person who is sick with or has died of Lassa fever, including blood, urine, vomit, breast milk, semen, and saliva. Transmission can also occur through direct contact with objects contaminated with the body fluids of a person sick with or who has died of Lassa, such as contaminated needles. Lassa virus has been detected in the urine and semen of Lassa fever patients for several weeks after the patient has recovered. There is no evidence supporting airborne spread of the virus between humans. The incubation period for Lassa fever is 6 to 21 days. The signs and symptoms include fever, retrosternal chest pain, pharyngitis, myalgia, headache, nausea, vomiting, diarrhea, neck swelling due to enlarged lymph nodes, abdominal pain, conjunctivitis, miscarriage, weakness, facial edema, and maculopapular rash. Hemorrhage can also be seen and includes mucosal bleeding, melena, and bleeding from puncture sites. Frank disseminated intravascular coagulation is rare. This graph depicts the frequency of various signs and symptoms in confirmed Lassa fever patients and patients diagnosed with a non-Lassa febrile illness. On first presentation, patients with Lassa fever have few pathognomonic signs and symptoms compared with other non-Lassa febrile illnesses. The lack of pathognomonic signs and symptoms makes diagnosis challenging without early suspicion and appropriate travel or exposure history. A review of 33 imported cases of Lassa fever found that the time from patient presentation for medical care to clinical suspicion of Lassa fever by clinical providers in their destination country ranged from 1 to 22 days, with a median of 4.5 days. This table depicts the general progression of signs and symptoms over the course of infection. During the first few days of the illness, symptoms tend to be mild in nature and include low-grade fever, chills, and malaise. Over the course of the next several days, patients exhibit signs and symptoms of a systemic viral illness, including nausea, vomiting, myalgia, and pain in the chest, epigastrium, and lower back. Headache is almost universally present and tends to be more frontal than occipital in location, and usually increases in severity later in the illness. Pharyngitis develops early and becomes progressively more severe during the first week, with oral ulcerations noted in half of the cases. Joint pain, particularly in the large joints, is common in this phase, as is low back pain. During the second week, severe lower abdominal pain and intractable vomiting is common. Facial and neck swelling with conjunctival edema and injection is frequently observed as well. Occasionally, patients demonstrate bleeding from the nose, gums, or needle puncture sites. The appearance of a maculopapular rash, cervical lymphadenopathy, crepitant rales, and deafness can also be seen during this phase of the illness. In survivors, fevers begin to resolve during the second week of illness, with occasional spikes in temperature. Other symptoms also begin to resolve. The mean duration of illness for survivors is 14 days, with a range of 11 to 21 days. Non-survivors develop hypotension, shock, agitation, or lethargy, and eventually obtundation. The mean duration of illness in non-survivors is 12 days, with a range of 12 to 15 days. Laboratory findings of patients with Lassa virus infection often include lymphopenia, with maximum depression at 11 days after illness onset, thrombocytopenia and platelet dysfunction, and proteinuria. Elevated liver enzymes with AST greater than ALT is also commonly seen. Coagulation factors, including PT and PTT, are usually normal, even in patients who develop bleeding. Signs of renal dysfunction can also be seen, with elevated BUN and creatinine values. Sensorineural hearing loss is a known complication of Lassa fever. The hearing loss can be temporary or permanent in one or both ears and can occur in 20 to 30% of patients. Hearing loss typically appears during early convalescence. The onset of deafness is always preceded by seroconversion and is thought to be immune-related. Development of hearing loss is not related to the severity of the acute illness. In pregnancy, Lassa fever causes high maternal and fetal mortality. Pregnant women with Lassa fever have significantly higher concentrations of the virus in their blood compared to non-pregnant patients. Vertical transmission of Lassa virus from mother to child has been documented. Lassa virus has been isolated from fetal tissue following a spontaneous abortion, and a high concentration of the Lassa virus has been detected in placental tissue. This table depicts the case fatality rate for pregnant women with Lassa fever by pregnancy trimester for one hospital in Sierra Leone. In this study, the highest risk of maternal death in pregnant women with Lassa fever was during the third trimester, with a case fatality rate of 30%. However, the overall case fatality rate in pregnant women is not statistically different from the case fatality rate among non-pregnant women admitted to the hospital with Lassa fever, except in the third trimester. Evacuation of the uterus by spontaneous abortion, evacuation of retained products of conception, or normal delivery has been shown to significantly improve the mother's chance of survival. In one study, 38% of women without uterine evacuation died, compared to only 10% of women with evacuation who died. This difference in mortality was statistically significant. Here is a table of fetal outcomes by pregnancy trimester for one hospital in Sierra Leone. As you can see, Lassa fever carries a high risk of fetal death throughout pregnancy. In this study, the overall fetal death rate in the first or second trimester of pregnancy was 92%. The overall fetal death rate in the third trimester of pregnancy was 75%. To evaluate signs and symptoms of Lassa in children, one study evaluated 479 children admitted with a febrile illness to 2 hospitals in Sierra Leone over a 4-year period. A total of 51 cases of Lassa fever were identified. The age range for Lassa fever cases was younger than 1 year to 14 years of age. 16 of the 51 cases were male. The overall case fatality rate was 12%. Of the 51 confirmed cases of Lassa fever, signs and symptoms were recorded for 26 of the cases. The most commonly reported symptoms were fever, cough, and vomiting. The most commonly noted signs were pharyngitis, lethargy, and bleeding. Overall, the signs and symptoms of Lassa fever in children were similar to those in adults. However, compared to adults, sore throat and pharyngitis were much less frequent in children. Swollen baby syndrome is a clinical syndrome that is distinctive and highly diagnostic of Lassa fever in children. It can be seen in the neonatal period, infancy, and early childhood. It is characterized by a triad of symptoms including widespread edema, abdominal distension, and bleeding. The edema of swollen baby syndrome is pitting, but in the extreme form can be tense like a balloon. There may also be chemosis and pulmonary edema with crepitations and foaming at the mouth. Initially, the edema may be confused with nephrotic syndrome. However, serum creatinine and albumin are normal, and albuminuria is minimal. Abdominal distension may be severe and tympanic, requiring placement of a rectal tube. Bleeding presents as hematochezia, melena, hematemesis, subcutaneous ecchymosis, bleeding from the cord, and bleeding from venipuncture sites. Swollen baby syndrome is associated with a poor prognosis. Here is a list of references cited in this presentation. Thank you for your attention.